Hi, everyone. We're very excited to present X-rays, which stand for Cross Radiology Artificial Intelligence Support. We'll introduce you to the fun Northwestern team later, but we'll start with introducing Mr. Jones. One day, he presents to the emergency department with nausea, vomiting, diarrhea, and fever. The ED physician orders chest X-rays due to the patient's smoking history. The chief resident then looks at the X-ray and decides it is normal. The patient was discharged home, and the preliminary findings of his report was not sent to the radiologist. The radiologist now looks at the X-ray and finds an ill-defined density in the left lung and recommends a CT scan. The report was filed into the medical record, but the ED physician never received it, and the radiologist did not have time to call them directly. So Mr. Jones had several medical visits over the next few years, but the X-ray findings were never raised.
So clearly they missed something in the web of communication. So just based on that vignette, we have an ED physician, we have a chief resident, we have the radiologist, but there's a ton of other healthcare professionals that are included in this giant web of communication. Other people that are potentially even more patient-facing, like the nurses, social workers, the primary care physician, many other healthcare providers in this web, which means that there's a ton of failure points where communication can fall through, as we saw in the vignette. The radiologist saw a finding, but there was communication droppage in some point from getting that to the ED physician. So this just went under the radar for a long time. So one patient by themselves sees tons and tons of healthcare providers. And if you expand from that, each healthcare provider themselves sees tons and tons of patients. And this very, very quickly becomes very complicated. So if we go back to the vignette, we come across a situation where there's an abnormal imaging result. The question becomes, who is the person who is responsible for actually contacting the patient, setting up some kind of follow-up, getting them back into the healthcare system so that this abnormal imaging result can be just followed to completion. And again, this is a super complicated web, so many points of failure. And we can see this in many different healthcare settings, from trauma service, HIV care, a ton of different lab tests. We've seen in the literature between 12 to 80% of patients are just lost to follow-up after receiving some abnormal results or trying to be followed up by the healthcare physician. So this is clearly a huge problem, and we'll go into like the specifics of that.
When we talk about the regular follow-up, we are talking about retention. Retention may be influenced by the health disparity. We found that racial and ethnicity minority, sexual and gender minority, and low-income people may have experienced challenging healthcare access, and their social conditions may also influence their health outcomes. And we found that prior literature shows appropriate and timely follow-up and care retention has improved patient outcomes in a variety of conditions. And the literature shows the retention may be limited to patient geographic and financial access to healthcare, their educational levels, and other social determinants of health. Then specifically to radiology, appropriate retention of radiology therapy is very critical aspect for patient safety and healthcare quality, because those data are very helpful for clinical follow-up, particularly in the instance of retreatment and recurrent disease. Studies have shown that non-white patients were less likely to meet each step of recommended follow-up imaging, and racial ethnicity minority, as well as patients in rural areas, have dismissed access to radiology therapy. We summarize barriers include the disparity in the provider-patient communication and the appropriate scheduling for follow-up visit.
And so returning to Mr. Jones to kind of ask what happened when there are these failures in communication. 3 years later, he presents to his primary care physician with a cough and shortness of breath. And based on these symptoms, the primary care physician orders another chest X-ray and notices these abnormal results from the prior study. So they were in the medical record, but they'd never been communicated directly to them. By this time, unfortunately, the mass that Mr. Jones had in his lung was a stage 3 non-small cell carcinoma without metastasis, or it was identified as being without metastasis at this point. But it was big enough that it was inoperable, and so he underwent an aggressive course of radiation and chemotherapy, something that likely could have been avoided if the initial follow-up visit had been completed.
So it's not at all surprising the number of gaps within our current care delivery model that reinforce barriers to access and widen healthcare disparities. Patient and clinician partnerships are often not well developed due to a variety of reasons, whether it be mistrust of the healthcare system, an inability to identify one principal clinician as their healthcare advocate, or simply a factor of the time we allow for clinical encounters. The consequences of this are not insignificant. In fact, it has been studied that because of these more loosely formed physician and healthcare team partnerships, there's less discussion in regards to screening, follow-up, or treatments when compared to non-minority or affluent patients. The current use of low-intensity interventions, such as generic letters, emails, phone calls, or reminders after a visit, may actually increase the health disparities among patients who may respond to these things at a much lower rate. Sadly, patients who would benefit from these very safety net interventions are not very well connected to them.
So I'm going to be going over our proposed solution that would hopefully address some of these gaps and prevent situations like Mr. Jones's from occurring. And this is a bird's eye view of some of the steps that we're proposing on taking, divided into 2 primary phases. The first of which is development and training of some of the algorithms that I'll be talking about, and then putting it into a real-time production where it's being implemented in clinical care settings. So to start, the first step of our development will be to use the National Library of Medicine's MetaMap tool to recognize concepts in radiology documents. And these are referred to as concept unique identifiers. So I have an example down here. The text, I've bolded a couple of terms: hyperdense, mammogram, and follow-up. And so what MetaMap will do in this first data processing phase is find these concepts and recognize whether or not they're positively or negatively indicated. So in this case, it recognized that dense or hyperdense was mentioned, a concept related to mammography was referenced, and follow-up was also referenced. But what's important about MetaMap is that this is a negative indication, so no follow-up indicated in this case. And MetaMap does this quite well when applied to unstructured documents such as a radiology text note. So once we've created this giant document concept matrix from our radiology document corpus, our next plan is to manually assign labels to a subset of these radiology documents and indicate whether or not they're indicative of needing follow-up or not. So I've shown the document concept matrix, just one row from that example that I showed in the previous slide. It's got dense, mammography, and follow-up there as features as inputs into our algorithms, and then the label we've applied, which will be manually applied for the training phase, as no follow-up indicated. And we're planning on applying a suite of machine learning models to this document concept matrix in this training phase to compare performance and decide which might be best to implement in the real-time phase. So finally, once we've done this development, trained models, compared performance on a validation set, the plan is to classify new radiology documents in real time as they're published in the electronic medical record system. And once they're classified, we would also like to integrate our system into being able to provide some type of notification. So providers, this would be in some type of direct EMR message. For patients, it would be their preferred mode of contact, which is normally indicated in the EMR system, particularly that's implemented in Northwestern, which is Epic. And to really set us apart, besides just the normal contacting that I'm sure many patients are overwhelmed with, what we'd like to eventually incorporate into this automated system is some type of automation of actually ordering different types of order sets that are relevant to the condition of interest, and potentially scheduling with the PCP or other care provider that's relevant. to sort of save the work from needing to be done manually by the many providers in that complicated web that was mentioned earlier. And in this real-time phase, we would also like to get provider feedback on a subset of notes that have been classified by our algorithm to see if it's doing what we're planning on it doing. If it's misclassifying a bunch of documents or ordering wrong document sets, we want to know about that. So we'd like to constantly improve this algorithm over time in this phase by getting feedback from providers.
At the heart of many safety and quality issues is that communication is often assumed to have taken place, to the point that it is the most common root cause of medical errors. We believe there are two facets to what makes our solution different. Firstly, from the patient context. We all live in this new world order where innumerable generic texts, emails, unidentifiable phone numbers are in a sense causing a social deafness from all the noise and volume of information coming at us. It's gotten to the point where it's become difficult to separate the critical from the mundane. And in healthcare, we know that can be deadly. Our solution will ultimately highlight these critical engagement pieces for the patient and make it easier to discern what is important by making communication more personalized and customized to their needs and preferences for language and cultural differences. The idea would be to improve continuity of care with fewer known contacts rather than multiple unknown ones. By keeping a patient in the loop throughout the entire life cycle of an intervention, such as imaging or clinical follow-up, we hypothesize that patients may more easily become engaged and empowered in their own decision-making. Communication is with the patient rather than at the patient. Next, for the healthcare teams, we believe that by automating orders and having them at the front and ready for the ordering provider, it will reduce time spent in the EHR and improve remembering to follow through on these incidental or critical medical findings within an already noisy workflow. By cutting back on the multitude of administrative tasks that are often inefficiently shared among the clinical team, we anticipate that we can provide the healthcare team enough emotional, physical, and mental bandwidth to then be able to focus on the more important things, such as the patient, their families, and communities. It is naive to believe that one single message within a medical workflow has gone to its intended reader and been acted upon, let alone in a timely fashion. We envision our solution to bridge communication with all the relevant clinical departments that surround the patient in a way that is efficiently exchanged, received, traceable, and ultimately completed.
So returning to Mr. Jones one more time, we started with him and we'll wrap up with him. 2 years after his last visit, there was another study done that showed evidence of a new tumor in his other lung. And during workup, it was determined that this cancer had actually already spread to his brain as well. He underwent aggressive chemotherapy and radiation again, but his health declined until he died 8 years after that first abnormal chest X-ray in the ED. And we could think about, we can't say for sure, but we could think about all the ways in which maybe the outcome here would have been different, would have been better had those initial abnormal findings been followed up on. So here's just a little bit about our team, some areas of expertise that we bring. I think we may be just running over time here, so I'll just say we've worked in various spaces on lots of projects, and we're excited to come together to work on this. You can see our names here, and I guess we'll take any questions from you all. Thank you.
Judges?
I can start. So you focused a lot on communication. So am I taking away the fact that you are identifying, when essentially when critical communication needs to happen? And then what I didn't capture was, how is that, just given the complexity of all the communication methods, how are you guaranteeing that it is landing? Like, what's that follow up, and how, I don't think I understood that well.
Yeah, that's a great question, and something that our team has discussed at length. It's important to recognize that every patient's situation is unique. For instance, one thing we talked about is a lot of patients might not have a PCP. So who are we contacting in that case? So we were thinking about leveraging or potentially looping in some community-based resources into the system, perhaps a social work team that would have a patient that has a document labeled as needing follow-up, having them added to a call list potentially getting some type of tech system that links a patient into various community resources to get them a PCP in the first place. Obviously, those are definitely some downstream things, and I think something the system could incorporate over time. But those are some of the visions that we had for our system.
Yeah, definitely important to think about the limitations of notifying a patient who otherwise was just told, oh, your x-ray was normal, you can go home. But had they known that it was abnormal, this patient, we think in this vignette, would have received better care, but that's certainly not the case for everyone. It's not as easy as just knowing, so that's important.
I think the idea is to also close the loop. So that also includes the messages we send to the patient. So we're hoping maybe one day to just do a registry or a sort of a waiting list of patients who haven't opened the message in some form, so that we continually and progressively and more intensively try to reach out to them, again, through community health partners as part of that, or social workers.
I'll add on to Maricela's comments that, every test, even if someone doesn't have a PCP, is ordered by someone. And so typically, I mean, like the responsibility is, we think of like, who does the responsibility fall on? Well, sometimes people do pass off responsibility to primary care, pass it off to other folks. But in general, I think it's like, from an ethical standpoint, like whoever orders the test is typically the one responsible for closing the loop, and is the person who has a hopefully therapeutic relationship with the patient, because they're the ones who order the test, presumably, after some conversation took place with a patient. So I think that in the case that you presented, if the inpatient team, for example, doesn't tell you the full report, just tells you the preliminary, in some sense, that's kind of on the inpatient team. That's not to say that doesn't need to be followed up, but that, that's there. And the other piece of context is just that, in 2016, there was the 21st Century Cures Act that was passed, which has an information blocking rule, such that when, nowadays, in the last couple of years, when a new result becomes available, you actually get if you have a smartphone, you actually get a ping. You have a new result such that you can read it. Not to say that's sufficient or that's necessary, but not sufficient. But I think that landscape is a lot different than 10 years ago, when, I remember for a family member going to a medical records department of a hospital and getting a result from them that the physician refused to talk to me about because they hadn't thought about it. And I was like, well, I'll just go to the medical records and we'll just get the printout and look at it ourselves. Those days are kind of gone. So I think just adapting your thinking to the new world where patients actually can get that in a way that they couldn't get it pre-2016 and probably even after that.
We're also considering the patient who doesn't necessarily have the literacy to get into their phone. I know even for my sweet mother, she gets a message that she got a result at NM, my portal, but doesn't really have the computer literacy to actually click in. And I don't know how many passwords we all carry around, but that's also a really difficult thing to remember the password to get into the portal. Some of options of that could be offline systems where there is an ability in their own language, depending on what that is or who they've appointed to speak for them, get that progressively.
Yeah, so I think, just thinking about whose problem is being solved, if a primary, if someone ordered the test and someone else is calling, that's obviously not ideal, because that person, someone else is calling who's affiliated with primary care, that's okay. But when there's, I think when someone doesn't have follow-up, doesn't have primary care, and, how do you know that when the result was communicated to that person in the hospital, are you going to re-communicate every result, or, the NLP is going to somehow figure out this was a result that didn't get correctly communicated, or where a preliminary change to a final and the read was markedly different. Many radiology departments have an actual flag where if the final result is different than the preliminary, the radiology department will actually call out to the ordering physician to say, no, you got to call the patient back. So I think you just figure out whose problem is being solved a little bit to get this to serve the right person's needs.
Thank you all.
Great. Thank you, Team Northwestern. Thank you, judges.